Okay. Um, I'd like to introduce and thank very much Terry Mamounas, MD, who is a medical director of the breast program at Advent Health Cancer Institute. He's a board-certified breast surgical oncologist. He received his medical degree from the University of Athens and completed a clinical oncology research fellowship at the University of Pittsburgh and a surgical oncology fellowship at Roswell Park Cancer Institute. Dr. Mamounas' career spans over 30 years. Since 1987, he's been the chair of the Breast Cancer Committee of the National Surgical Breast and Bowel Project, that's the NSABP, and NRG Oncology. Dr. Mamounas has published extensively in the field of breast cancer and has presented his research nationally and internationally. And he is also the first author of a study that we're interested in discussing today with him, as we think it will be interesting for our population. This was the results from the NSABP B51 study that was published in the New England Journal of Medicine. So Terry, welcome, and thank you again so much for joining us today, for joining me.
Thank you. It's a pleasure to be with you.
Thank you. So I'm going to just ask you a few questions about this B51 study for our audience. And, you know, in the big picture, this study was about the need for radiation after neoadjuvant chemotherapy delivered before surgery for women who have no cancer left after this treatment. So can you tell me a little bit about the history that led to the study?
Yes. So, for many years, we have a lot of studies that have shown that the use of radiotherapy after mastectomy and to the nodes that were positive when patients have surgery first significantly improves outcomes. There are many studies, many meta-analyses that show that radiation clearly improves outcomes for patients that have positive nodes. But for recent years, we started using more and more preoperative chemotherapy for some patients that meet criteria, in particular for patients with what we call triple-negative breast cancer, patients with HER2-positive breast cancer, and some select patients also with estrogen receptor-positive or hormone receptor-positive and HER2-negative breast cancer. Typically, the patients who present with larger tumors with nodal involvement are good candidates for preoperative chemotherapy, and again, with particular subtypes be benefiting more.
Mm-hmm.
So it became fairly common to have patients who present with positive lymph nodes who would have required radiotherapy if we did surgery at that time. But because we took them through the preoperative therapy pathway, the nodes then became negative after they received preoperative chemotherapy and went to surgery. So we had the situation not uncommonly where patients with positive nodes before neoadjuvant chemotherapy now have negative nodes at the time of surgery. And so there was not much information for these patients to tell us how they will behave. Will they behave like positive patients because they were not positive before and will have high rates of local recurrence, in which case radiotherapy would be beneficial? Or would they behave like non-negative, which they were after neoadjuvant chemotherapy?
Mm-hmm.
So we had some data from retrospective studies from some of the cancer centers showing that it was difficult to predict how radiotherapy will affect these patients. Some studies have shown some benefits, some studies did not. But what became apparent from a publication from the NSABP previous preoperative studies, the NSABP B18 and B27, when we looked in a combined analysis of factors that predict locoregional recurrence in these patients. And what we found was that the initial presentation played a role. For example, if they presented with positive nodes or big tumors, or for younger patients who were even higher rates, but also consistently a factor that predicted for low rates of local recurrence was the conversion of patients to negative nodes if they had positive nodes, and also to having no disease in the breast at all, having what we call a pathological complete response. Mm-hmm. So consistently, pathological complete response was shown to be a predictor of better outcomes, both in terms of systemic recurrence, but also in this case for local recurrence. So obviously that led to having us ask the question, If the rate is lower, then maybe they behave more like non-negative,
Mm.
and maybe they will not benefit from radiotherapy because similarly, as I mentioned earlier, the studies that had shown benefit from radiotherapy for node positive patients did not show benefit from radiotherapy for non-negative patients. So if you were non-negative, you had surgery up front, there was no role for regional radiotherapy, regional nodal radiotherapy, or post-mastectomy radiotherapy. So this actually provided the rationale for the study to prove whether if we downstage the nodes to negative from positive,
Mhm.
would radiotherapy then have the same effect as we have expected if surgery was taking place up front? So
Perfect.
that was the rationale for the study.
That's excellent. So people allowed in the study were women without metastatic breast cancer who were recommended to receive neoadjuvant chemotherapy, and then were randomized at the time of surgery if they had a pathologic complete response, so lymph nodes negative as well as no tumor in the breast as well.
No, the breast, we
Just the
allowed
nodes.
both to
Okay.
have a little disease in the breast as long as the nodes were negative. And about 80% of the patients in the study had both pathological complete response in the breast and the nodes, but about 20% had residual disease in the breast, but they had cleared the nodes.
Okay, great. Um, and they were allowed to have mastectomies as
Or
well
breast
as,
conservation. Yeah, mastectomy or breast conservation
okay,
was allowed. And if you had breast conservation, you were supposed to receive breast radiotherapy. That was the standard, whether you were randomized to the regional nodal radiotherapy group or not. But if you had mastectomy and you were randomized to no regional radiotherapy, you did not receive anything. No chest wall radiotherapy, no regional nodal radiotherapy. But if you were randomized to the regional radiotherapy group, you received post-mastectomy radiotherapy and regional nodal radiotherapy.
great. And then I saw that they were, as far as lymph node involvement, they were allowed if they had a clinical N1, they couldn't have more expansive nodes. So they couldn't even have imaging evidence, I assume, of intramammary nodes, certainly supraclap nodes. Is that correct?
Yeah, so the criteria for the study was to have tumors in the breast T1 to T3, essentially operable breast cancer,
Yes.
with tumors either less than 2 centimeters to 5 or over 5. They were allowed as long as there were no T4, essentially skin involvement, inflammatory carcinoma, and any of that.
Mhm.
And as far as the axilla, they had to be clinical N1, which essentially per staging system means that the nodes were palpable, potentially positive, but not matted. In other words, the nodes that were not joined together. And
Mhm.
that's the only criteria. Now, uh, we did not either demand or prohibit to have additional imaging testing. So there
No.
could be the situation where a patient may have had an MRI that showed 3 or 4 or 5 nodes that were abnormal or an ultrasound. That was not an exclusion criteria. I suspect, though, there weren't a lot of patients like this because people obviously screened them before, since this was a study that departed from the standard of radiotherapy.
Yeah.
So, but it's possible that patients with more than 3 nodes involved were included in the study because all we asked was the nodes either
Mm.
palpable, clinical in one, and not matted.
Sure.
And of course, they had to be biopsy proven. So if a lymph node was abnormal either by palpation or by imaging, they had to biopsy that lymph node and tell us that this lymph node contained disease.
Great. Perfect. And yeah, I would suspect if someone was worried and they saw imaging of more extensive nodes, understanding that at the end of this, the patient could be randomized to no radiation, they might be conservative. So it might represent just
Right.
exactly what you thought, and probably more
Yes.
N1 disease, like
Yes.
even pathologic. Okay, great. So an exciting study, an important advance for women with breast cancer, re-examining now that we often give in certain settings, at least chemotherapy before surgery, interpreting what that means. We've known and shown that obviously if you have a complete response to chemotherapy before surgery, you do better. The question is, how does that affect
Please.
locally how you do? So excellent.
Right.
Can you tell us the findings of this exciting study?
Yes. So the study's primary objective essentially was to compare the effect of regional nodal radiation in terms of invasive breast cancer recurrence-free interval. What that means is time from randomization to development of either breast cancer recurrence, local, regional, or distant, or breast cancer death. That was the primary endpoint. And of course, there were several secondary endpoints: local recurrence-free survival, distant recurrence-free survival, overall survival, disease-free survival, and of course, toxicity. So these were the primary endpoints of the study. And the study accrued patients between 2013 to 2020. So we did have initially hard time accruing to the study, not surprisingly. I mean, it was a departure for people to potentially consider 50% not giving radiotherapy. But over time, the study started to accrue more and more, and eventually we're able to complete it in about 7 years.
Mhm.
Now, we were supposed to analyze the study two different ways. One was if we encounter 172, as we call 172 primary events, which essentially were recurrences, death from breast cancer. Another way, though, we have pre-specified in the protocol is that if we completed 10 years from the first patient accrued in the study, then we would analyze the study even if we didn't have the number of events that was required to our 72. So when we reached the 10-year mark from the first patient in the study, which was from 2013 to 2023, we noted that we had 109 events, not 172 that we have pre-specified. But because it was a pre-specified analysis, we broke the code essentially and reported the results in San Antonio in 2023. But having less events obviously decreases a little bit the power of the study, right? Because on an event-driven analysis, you have to have so many events before you can statistically say there is a difference. On the other side, though, the patients in the study did better than we anticipated. Right. Now, this could be a little bit because of selection bias and avoiding some patients that you may suspect will have more disease. It could also be because the treatments change over time, and we adjust for that when we try to predict how many patients we need in a study, how much power we will need to have. We adjust for that because data that we use from the B18 and B27 study was conducted previously, we adjusted downwards about 15% or so, because we know that in any study that is reported nowadays, the outcomes are better for a variety of reasons, including better detection, better systemic recurrence detection with PET-CTs and all kinds of other tests that we do. So we knew that the patients that entered the study ended up having better outcomes, which is good for patients represented in the study. So we accrued a total of about 1,641 patients, and of course, then some patients, didn't have follow-up. So we ended up with the primary analysis of 1,556 patients. So very similar to the original. And the median follow-up at the time that we presented the data was close to 5 years. It was almost 59 and a half, almost 60 months of follow-up. When you look actually at the patient characteristics, there were representation of multiple factors. For example, age of the patients, about 40% of the patients were under the age of 50. So younger patients were represented. Also, African Americans were overrepresented because obviously they get a lot more triple negative breast cancer, which is a breast cancer that responds to chemotherapy. That was overrepresented in the study. So 17 to 18% of the patients were African Americans. And then in terms of clinical tumor size, the majority of the patients were T2, but about 20% were T3, and the other about 20% or so were T1.
Okay.
But of course, everybody had positive notes. And if you look at the subtypes that were included in the study, not surprisingly, the most common subtype was HER2 positive. The subtype where about 50% of the patients were HER2 positive. Some were ER negative HER2 positive, some were ER positive HER2 positive. And then about 20% were triple negative, and 25% were ER positive or hormone receptor positive and HER2 negative. So we have all the subtypes represented. Lumpectomy was the surgery in about 58% of the patients, and 42% had mastectomy. And then staging of the axilla was allowed to either have axillary lymph node dissection or sentinel lymph node biopsy. And axillary dissection was about 45%, and 55% of the patients had sentinel lymph node biopsy. And the only requirement for the study was you have to at least have 2 sentinel lymph nodes removed. And that came a little bit later after we started the study. But once we had the results of another study from the ACOSO group, the 1071, it became apparent that you had at least 2 nodes to minimize the false negative rate. And of course, at that time, we weren't doing what we call now targeted dissections. They weren't that popular, but some of them may have had that at some point. And then as I mentioned before, pathological complete response in the breast also happened in about 80% of the times, but in 20% of the patients, there was still some disease in the breast, but not in the lymph nodes.
Okay.
So when we looked at the primary endpoint with the invasive breast cancer recurrence-free interval, we saw no significant difference. So in other words, radiotherapy did not improve outcomes of the patients in terms of breast cancer recurrence and death from breast cancer. And there was about 9-event difference between the two. The 109 events were 59 in the no-radiation group and 50 in the radiation group. So the absolute difference at 5 years was less than 1%, 0.9%. And of course, it was not a statistically significant difference.
Yes.
And then when we looked at all the secondary endpoints, very similarly, we did not see anything. In local recurrence-free interval, the difference was also about 0.9% in favor of the radiotherapy, but not statistically significant. There was very few local recurrences. In fact, in the publication, there were 11 recurrences, local recurrences in the no radiotherapy group and 6 in the radiotherapy group. Now, there is a little bit of a trend there. Most of the recurrences were in the axilla or the infraclavicular area. But again, that number was not statistically significant. And essentially, it's a handful of recurrences among the 1,500 patients that participated in the study. And as far as disease-free survival, distant disease-free survival, overall survival, there's absolutely no difference. In fact, the lines are totally superimposable, at least with the follow-up that we have at this point. And we did the subset analysis to look to see how the effect of radiotherapy varied, perhaps, across different characteristics. For example, look at the type of surgery, lumpectomy or mastectomy, and we don't see a significant difference. When we looked at all what we call the stratification variables, which is essentially type of surgery in the breast, estrogen progesterone receptor, HER2 receptor, pathological complete response in the breast also or not, and whether adjuvant chemotherapy is given, which was very rare anyways, we did not see any interaction on the effect of radiotherapy. So we can conclude from that irrespective of the type of surgery, receptor status, HER2 status, or pathological complete response in the breast, there was no significant difference in the effect of radiotherapy. Now, if you look at the hazard ratios, they vary a little bit. Sometimes they go a little bit towards the radiotherapy, but the confidence intervals are so wide that essentially there's no difference. We also did another subset analysis that was unplanned, but we did an analysis according to the subtype. I mean, other factors as well, like age of the patient, race of the patient, or axillary surgery. There was no difference in the effect of radiotherapy to those. But the only interaction was in terms of subtype. And what we found was that for the triple-negative patients, for reasons that is very hard to explain, those that did not receive radiotherapy did a little bit better than those that did. Almost like twice as many recurrences occurred in the radiation group versus the no radiation group. So that's a little bit food for thought. We don't know why that is. Is it immune-related? Is it just chance alone? Of course, it's about 25% of the patients in that group, so the numbers are small. So we have to follow that. Yes. But there is something, and again, what I've said about that is that because of the patterns of failure of triple-negative breast cancer would typically recur early, yes. I think we're past that prime. So I don't think these results would change. In other words, I feel a lot more confident that the ER-negative, triple-negative patients will not have any benefit, and the hazard ratio will always be on the other side for whatever reason. The opposite, though, in the ER-positive and HER2-negative patients, we did see a trend towards benefit. So the hazard ratio was like 0.41, so there was about a 60% reduction. It barely was statistically significant. It touched 1 in the hazard ratio, but the interaction was statistically significant. Now, for those patients, the local recurrences and distant recurrences may occur later on as well because they have a different pattern of failure. So we have to be a bit cautious, and we discussed that in the paper. The other thing about these patients is that sometimes they may present as having a pathological complete response, but if you did a sentinel lymph node biopsy, it's possible that you may miss a lymph node, right, that was there. So they have a different pattern of regression. And so for those patients, we're a little bit cautious because we want to make sure, and some previous data have shown also that these are the patients that benefit a lot from radiotherapy, post-mastectomy radiotherapy, some of the older studies. But again, the interaction there was statistically significant. The HER2 positive patients seemed to benefit from, did not benefit from radiotherapy, no matter what the subtype was. So I think it's fair to say that for the triple negatives and HER2 positives, I think these results are practice changing. And they could be also practice changing for the ER positive, HER2 negative. But there, I would say having a pathological complete response in the breast is important because if I have a patient where it doesn't have a pathological response in the breast, one can question, does he have a pathological complete response in the nodes, or did we maybe miss the node that had the
Right.
disease?
Yeah,
Now,
particularly at a targeted dissection, you might.
the targeted dissection now has improved the false negative rate down to almost like 2 or 3%.
Mhm.
But some of the patients in the study may have gotten in with a false negative rate potentially of 8, 9, 10%. So it's
Right.
possible that some patients may have been
Right.
sort of uh, uh, assessed in a way that potentially you could have missed some disease. I mean, that's possible even in accidental dissection. Sometimes you may miss a lymph node
Sure. Yeah,
have
definitely.
disease. So we'll continue to follow. Of course, we'll present data with a lot more follow-up now. We're still waiting to get to the 172 events, which will
Mhm.
give us the power that the study was initially designed to have. But
Fantastic.
essentially, this study, to conclude, is that it was really it's a paradigm changing study because
Very
it
much.
proves that if you can actually eliminate the disease but systemic therapy in the breast and the lymph nodes, in the lymph nodes primarily,
Mhm.
then local regional therapy is less needed. Right,
Yes.
that's the idea. And of course, other people now starting to think about maybe we can omit surgery as well.
Yeah,
Why do
that
we
was
do
some of my
surgery?
questions for you.
And
Yeah.
I think it's a reasonable question. The issue with doing surgery, though, it's almost because we need to know
I know.
if they have pathologic response. So you have to take something out of there
Right.
to demonstrate.
Right.
Um, but there are studies that actually try to address that. Um, Initially, in the breast, for example, the studies where we try to do biopsies in the area of the tumor
Yeah.
bed if the tumor went away, but
Hmm.
we weren't very accurate in predicting pathologic response. That's why we did not move forward with a
Yeah.
randomized trial. Some now are trying to say, well, if you have a pathological complete response in the breast and the nodes presented as clinically non-negative, then you have a high probability that the nodes are pathologically non-negative if there is this pathologic response in the breast. So there are studies now trying to omit sentinel lymph node biopsy for these patients.
Sure.
But of course, if you do the surgery, you find that do have PCR, then you have to go back and do the sentinel node after. So it's kind of,
Mm.
you may do two surgeries in about, 20% of the patients or so.
Yeah.
So yeah, the results are paradigm changing because it allows us to capitalize on the systemic therapy effect
Yes.
that's gotten better and better. And even after this study was completed and now we have results, the treatment of subtypes of the breast cancer has changed. The triple negative breast cancer has gotten a lot better with the introduction of carboplatin, with the introduction of checkpoint inhibitors. For HER2 positive breast cancer, dual anti-HER antibodies. I
Right.
mean,
So
things
good.
are getting better and better.
Hmm.
And I've said this many times before, is like in breast cancer, if one modality was so good, all the other modalities would not be needed. If surgery would cure everybody, we won't need any adjuvant therapy. We won't need radiation, but that's not the case. If
Yeah.
systemic therapy
Systemic.
cures
Yeah.
somebody, then you don't need radiation. You don't need surgery. So I think we're getting down that path, possibly.
We're getting close.
Uh,
Yeah.
yes, we get,
I,
in some sometimes you're getting close for sure.
yeah, I've certainly been impressed by particularly responses to Herceptin and the new Herceptins, just people even with disease that is not so localized, having amazing
For sure.
responses and really
Yeah.
seeming
And sometimes
cure.
there are patients that survive 10, 20 years with metastatic disease,
Right.
HER2
Yes.
positive disease, because they're essentially cured. And we may see some of those now with immunotherapy as well.
Yeah, that'll be
Essentially.
interesting. We're
Yeah.
very interested in that and balancing the side effects. So fantastic. Obviously, definitely paradigm changing, very important for women with breast cancer. Keeping up with current, we're partners with the systemic treatments and the surgery and the radiation. We're all working together. It's impressive to pull off such a large trial. It is so hard. And I encourage all our followers always to join a trial. Many of you have at MiraKind. A couple follow-up thoughts or questions. So I'm sure, um, so we do a lot of biomarker research, and there are two areas that we've looked at recently. One is predicting side effects from radiation. I'm sure that there was more toxicity in the patients that got radiation in the study, of course.
Yes, a little bit more.
Yeah.
Yeah, with more radiation dermatitis, about from 5% to like 10% or so.
Yeah. So we do a lot of work looking at actually late toxicities, which are more fibrosis based. We do a lot of work in prostate cancer, but we've just applied that work in breast cancer. We're very excited. We have a really nice signature predicting that. Um, and I wonder at some point if you have this ER positive person that you're a little on the fence about, and they're at risk of and they had a reconstruction and they're at really high risk of a late significant radiation toxicity. I wonder how that might weigh in your mind as that becomes validated. Do you feel like that would be helpful information?
Yeah, absolutely. I think that as we see more follow-up, and I think the ER positives may still have some benefit, even if it's not significant. And there it becomes a biomarker sort of situation where you can pick out maybe those that either benefit or have more detriment from in terms of side effects. And we actually have a sub-study on quality of life assessment for patients that had mastectomy and reconstruction, and they were in the study to see what was the effect of reconstruction and radiation together, which we know it increases the complication rates, it increases the cosmetic effect. Sometimes loss of implant can happen. And so absolutely, I think that's when there is a little bit of benefit or something, then that's where you can apply biomarkers and pull out a group of patients that potentially do need it.
Okay.
Particularly, as you said, if they don't get any of the side effects or minimize the side effects, then all the more reason to be on the safe side and say, well, do it.
Yeah.
So, but on the opposite side, if you have a lot of side effects, you say, well, that may not be worth.
Right. And standard of care
Right.
is that, not treating is an option. It's all about, personalization, something we're very interested in.
Absolutely. Absolutely.
Fantastic. I'm trying to think if there are any other questions. So if you had a patient that came out, I have one other question about the triple negative patients. I'm curious how many of those might have been BRCA mutant and gotten carboplatin because we know they have such a fantastic response to that. Was BRCA testing required? It just or what?
It was not. It was not. And unfortunately, we don't have blood, but we may have tissue, and potentially you may be able to, with new technologies now, with next-gen sequencing potentially. So it's still a matter of, further research to look at those subtypes. There's some things that, in retrospect, we wish we could have
Of course,
collected.
it's always like that.
People have asked about isolated tumor cells,
Mm,
and those are not that common in the grand scheme of things
yeah,
in a neoadjuvant setting. But we consider those non-negative, so they're in the study. We didn't ask them, and so
yeah,
we didn't notice it. We are undergoing now. We're starting to undergo a pathologic review of the information that we have, like looking at all the pathology reports and things, just to see multiple things. Number of removed nodes, number of
sure.
positive nodes, or negative. I mean, negative nodes with treatment effect, and things like that. And maybe there we can have more room to actually apply biomarkers of benefit and even radiation, biomarkers as you mentioned.
Great. Fantastic. Anything else about this study that you think we missed talking about? Again, it's an amazing advance, such a humongous effort, and very impressive that you pulled it all off.
No, the only thing I mentioned is that obviously this was a collaboration of multiple organizations and people. There was NSABP 51, but also RTOG 1304. So this was an idea that was circulating
Oh, yeah.
in the RTOG community and NSABP community. And then at the end of the day, we joined forces and did the study together, and we were able to complete it. Because as you know, previous attempts, for example, for post-mastectomy radiotherapy mission failed
Yeah.
because there was, mission of a post-mastectomy radiotherapy, a SWOG study did not complete accrual.
Hmm.
And unfortunately, the escalation studies are difficult because people
Right.
are very entrenched and they feel like what they do helps patients. And so trying to take away something, particularly patients like we present with positive nodes and
Yeah, you
they're high
worry that
risk,
they're young
right?
and they're
You
triple
worry, they're
negative
young,
and they're like, I
right?
can't do anything else. I feel that way when I
Right.
see those patients. You worry
Yes.
because if
Yes,
they
you
recur,
worry.
that's very serious. And Yeah.
actually, exactly right. It's a very serious situation, like a triple negative, for example, to
Yeah.
recur.
Yeah.
Uh, yeah, they are positive to have some salvage potential, but yeah, triple negatives are very tough. So yeah, I mean, I'm happy that this went through and we finally got some results to talk
Yeah.
about and changing the treatment of patients.
Amazing. Well, thank you so much for your time. It was wonderful
My
talking,
pleasure.
and we love keeping in touch with you and keeping
Absolutely.
posted as we evolve and getting your excellent expert
Yeah,
input and appreciate it.
absolutely. Thank you very much for having me.
Thank you so much.
All right.
Bye-bye.
Take care. All right. Bye.